Thank you very, very much for joining us here this afternoon. My name is David Griffith. I'm the Director of Programs and Outreach for the LGBT Elder Initiative. I just want to take a moment to welcome you to our program, Aging Safely, Preventing Elder Abuse, Neglect, and Exploitation. I'd like to start off with just a couple of logistical details. Bathrooms down the hall, all the way down the hall to the right. There's a gender-neutral restroom there. Also restrooms on the first floor that if you take the elevator down are handicap accessible. There are some stairs here. We'd like to give a thanks to the William Way Community Center for hosting our program here today in their ballroom. It's a great space for today's event. And also want to give a big thanks to our presenters who will introduce further in just a moment here. As I mentioned before, if folks could take a minute to please complete the sheet in their folders that's listed, please help us with your demographic information. This just helps us to collect a little bit of information for our funders when they have questions about who's coming to our programs and who we're reaching with our program. I'm going to turn things over momentarily to Joe Quinn, who is a volunteer on the LGBT Elder Initiative Program Committee, and is going to be facilitating much of today's program. He's been doing a whole lot of work with our program committee, the planning committee for today's program, to get everything all set for you and kind of set today's agenda. So I'm going to turn it over to Joe Quinn.
Thank you, David. Appreciate that introduction. Again, welcome everybody. Thanks for coming to our presentation today. So, elder abuse, that's our topic. And why, you might wonder, that topic today, why is it so important to us right now? Why should we be concerned with this issue right now? It comes in many forms, as we'll find out from listening to our presenters. But basically, it can be defined as an intentional act or a failure to act that causes harm to an older adult. We should be concerned about this for several reasons. For one thing, we are older adults. We live in Pennsylvania, which has the fourth largest population of seniors in the United States. By 2020, there should be about 3.3 million Pennsylvanians over the age of 60. So we're obviously in the category of elders. For another thing, many of us identify as lesbian, gay, bisexual, or transgender. And it's estimated that there are about 27,000 LGBT elders in the Delaware Valley, and about 3 million LGBT Americans are over the age of 60. So again, another reason for us to be concerned and interested in this topic. And the LGBT population, we could possibly argue, is even more vulnerable than the non-LGBT seniors to abuse. Historically, we've lacked easy access to medical, social, legal resources for self-protection. Not to mention that 20% of LGBT older adults are said to have no one to turn to call on if they have a crisis in their life. So, the senior population continues to grow. A lot of us could be at risk for becoming abused, neglected, or exploited. It's a critical issue we felt that we could no longer ignore. According to the Pennsylvania Department of Aging, there were more than 20,000 cases of elder abuse in the most recent fiscal year. And it's estimated that actually 5 million Americans older Americans are victims of abuse every year. 5 million. Now, aging, of course, can all bring with it a lot of typical, normal aches and pains, and sometimes some even more serious medical issues. But no one should have to deal with, in addition to that, the insult of abuse from any form, from any person, and from any source. We all deserve to age safely, which is what we're all here to learn about today. So we brought together a panel of these experts who are well qualified in various fields, and to help us get a better view of this topic and answer some questions we probably all have, like what are the most common types of abuse? What are the signs of abuse? Who are the most common victims? and perpetrators of abuse, what can we do to help, and perhaps most importantly, what professional resources are available to help those who are in danger or are at risk. That's what our panel is going to help us with. I'll just give brief introductions to these folks right now. Sitting right here is Joseph Snyder. It's okay if I Joe. Sure. He's the director of Older Adult Protective Services at the Philadelphia Corporation for the Aged, PCA, as you probably know. Then we have Dana Goldberg, staff attorney at the Senior Law Center, where she's the coordinator of Project SAFE, S-A-F-E, for Stop Abuse and Financial Exploitation. We have Diane Menio, who's the executive director of the Center for Advocacy for the Rights and Interests of the Elderly, which you probably know as CARE. And we have Dr. John D'Antonio, who's an assistant professor at the Jefferson University Hospital, where he works as a geriatrician and a palliative care physician. So, if you looked at your agenda, you'll see how the program is going to work. First, we're going to have a sort of general overview from Joe Snyder, broad overview of the elder abuse crisis, and then each of the panelists will give a more brief talk about their own agencies, the types of abuse they've encountered, how they deal with them, and the resources they can offer. And then we'll have a session, we're calling those scenarios. We've developed, along with their help, some examples of somewhat typical cases they may have handled or will most likely handle. You have those in your presentation. By the way, you also have full biographies of all the folks at the table. They're in there. You have copies of the scenarios that we'll discuss. And then after that, we will have a general open Q&A. Everyone will have a chance to raise their hand, ask questions, or we could write down questions on their cards.
My name is Joe Snyder, as Joe said. I'm happy to be here, getting out the word on elder abuse and working in it. It's been my life's work. Been doing it for 25 years at the Philadelphia Corporation for the Aging, and I'm going to give a overview of the history of the movement, both from the federal, state, and down to the Philadelphia level, and talk about some of the prominent studies and issues in the field, and then talk a little bit about the end and hand it off to my fellow panelists. So when we talk about abuse, neglect, and exploitation, we are talking about physical abuse, emotional abuse, sexual abuse, caregiver neglect, self-neglect, and financial exploitation and abandonment. So of those, again, physical abuse, emotional abuse, sexual abuse, caregiver neglect, self-neglect, and financial exploitation, which do you think we see the most? Which gets the most reported to us?
Sexual abuse.
Sexual abuse, no. Financial, no. Physical, no. Self-neglect. Can you give her a prize? So, self-neglect, the financial exploitation is the fastest rising, and it's the one that has everybody's interest because there's so many different players in it. And as I say to my colleagues across the country, whether we like it or not, financial exploitation is dragging our field, and we'll talk a little bit about that. But another question coming up, the unofficial or even official start of elder abuse policy in the United States at the federal level started at what decade? Come on, you can guess. There's only so many decades. 80s? No. I like those.
1892.
1892, that's correct. 60s? No. 50s? 1950, which is startling in a lot of ways. So it started in 1950 when the government gave out demonstration grants to people to start elder abuse projects. It moved rather slowly, as you'll see. It picked up a little in the 80s, and there was a major paper written called Elder Abuse and National Disgrace in 1985. And what it said is we have to have a program based on, just like child protective services and child abuse, we have to have a law and programs based on that. Well, that didn't happen. So when I first started in this field, I would say, you know, it's almost been a half century and we still don't have a law. Then I would say, it's been a half century and we don't have a law. Then I would say, it's been 55 years and we don't have a law. And then finally I got to say, it's been 60 years and we have a law. A called the Elder Justice Act. Now, the Elder Justice Act was passed as part of the Affordable Health Care Act and represented the first federal funding to adult protective services, and it had actually 13 different appropriations, and it was something we've been waiting for our whole life. Unfortunately, there's two parts to getting the bill passed. One is getting it passed, and the second is putting the money in it. So as we sit here today, none of that money has been put into the act since 2010. Every year, the president puts something in the budget as a marker. In 2017, he put $10 million in the budget for the marker, just to keep it going, but nowhere near what we need. So the field, all the field, the members here and members of my organizations and others, we both in state and federal, we did a lot of things. So in 2001, there was an elder abuse summit in Washington, where stakeholders from all over got together, and we had 10 major glowing things we were going to get done, and they got done a few of them. One was passing the Elder Abuse Act when it happened, and then it kind of died off, and then a couple of years ago we had what we called the Elder Justice Roadmap Project. We use different terms when we talk about this. We use elder abuse, we use elder mistreatment. Elder justice is a term that's in vogue right now. So that project came in, and it's making little headways, but not what we should be doing. So let me give you some of the studies that are prominent in our field that we've known for a long time. Some of them for a long time, some recently. People who are abused, neglected, and exploited are 3 times more likely to die. They're 4 times, and I say all the time, if I said, Pura. If I said people who drink Pura are 3 times more likely to die, I would think it would be Gulf Market. The fact that I said people who are abused, neglected, and exploited are 3 times more likely to die, pretty much, that was 1998, by the way, pretty much got a collective shrug from the world saying, well, that's unfortunate. 4 times more likely to go to a nursing home, as I said earlier. MetLife Mature Market Institute says that elder financial exploitation costs us $2.9 billion a year. TrueLink Financial Services says financial exploitation costs us $36.48 billion a year. AARP just put out a paper called Bank Safe, and in it they cite that financial institutions are losing $1 billion a year to the plague of elder abuse. So despite all that, and there is movement, there's different movement, but it's not been what we need. The best study we have on prevalence comes from New York State and Cornell and Lifespan of Greater Rochester, who says only 1 of 24 of these cases are reported anywhere. And when it comes to financial exploitation, only 1 in 44. And when it comes to neglect, only 1 in 57. So we that do this, and we know we do it, we struggle with it. We're seeing, the tip of the iceberg, as we always say. Don't know what we would do if the iceberg started rising out of the water. That would be something that we do. So one of the things that happens is when and it can't be underestimated, when you don't get the federal leadership you need, in my field, adult protective services, each state evolved on its own. So that means that each state, 50 states, 50 statutes, different eligibility requirements, different populations. Some things are in some law, some things are in not other law. For instance, there's a number of states that are age-based. You only need to be a certain age and you're eligible for services. And not in Pennsylvania, we'll get to that in a bit. Other states, when we get to financial exploitation, for instance, in Tennessee, it's only financial exploitation if it's government money that's being exploited, in my field. Anybody else that has to report somewhere else. There are a number of states, even though I told you in the beginning that self-neglect is the one that gets reported the most, but it's not in their statute because self-neglect is the only one that doesn't have a perpetrator. And in some states, self-neglect is the purview of the behavioral health side of the game because they figure self-neglect, it's depression or some other kind of thing, and sometimes it's loneliness and sometimes it's other things. So those things happen, and then it's hard for the field as a whole to move forward because you've got all these different things. We're measuring different things, we're talking about different things, and doing things like that. So we have a national organization called the National Adult Protective Services Association. It's 25 years old, and in fact, the national conference is in Philadelphia this year, the week before Labor Day. And along with the conference comes a Elder Financial Exploitation Summit that we do every year behind the conference. And in last year's summit, we announced that we have formed the National Institute on Elder Financial Exploitation along with Hunter College in New York and the University of Texas at Houston. And we're going to be rolling that out this year. Right now we're building up the money and we're building up our task. So we'll be doing that. Pennsylvania, I mentioned earlier, has 5 criteria. It's not just you have to be 60 or older. You have to be 60, for me, not for everybody. You have to be 60. You have to lack a responsible caregiver. You have to be at imminent risk to self, property, or resources. And you have to be, this is a poor choice of words, incapacitated. But what it means in English, it doesn't mean incapacitated under guardianship law. It means something is stopping the older adult from helping themselves. So something is stopping you from helping you, and you're 60 and you don't have a responsible caregiver, and you or yourself or your property is at imminent risk. And then we can take the call and we can offer services. And I'll talk a little bit more in depth of that in a few minutes. PA is considered a mandatory reporting state, but it's kind of deceiving because only a couple people, abuse of a care-dependent person, facility employees and administrators are mandated reporters, and agents of the Department of Aging, Health and Welfare are mandatory reporters under neglect of a care-dependent person in the criminal codes. So even though we fall on the mandatory reporting side, and I think New York's the only one who still has no mandatory reporting whatsoever, really is a small amount of cases that have to be mandatorily reported. Any of the voluntary ones dwarf that. So we have to be careful about that. PA is done well. We have task force all over the state, and we have a task force here in Philadelphia called the Financial Exploitation Prevention Task Force. And Dana and Diane organizations are on the task force, as well as the police and the DA and about 6 financial institutions and the University of Pennsylvania Healthy Brain Memory Center, because the aging brain has so much to do, especially around financial exploitation. The Alzheimer's Society, Homeland Security, we have a really robust task force, and there's task force all over Pennsylvania. Pennsylvania's been good about that. We also have a Supreme Court task force on elder abuse. Diane's a member of that. She may talk about that a little bit. We also are lucky in Philadelphia. And if you weren't going to talk about it, sorry.
I will.
Okay.
Thank you for reminding me.
Yeah. So we are really lucky, because I mean this in all sincerity. Both Carey and Senior Law are the best in the country at what they do. And you have them in Philadelphia. So we're lucky that we have that kind of resources. And we've done a pretty good job in our way. We partnered with Wachovia Bank in early 2000 to provide a fraud prevention program. Because when I looked at this at the end of the 90s, I said, people that do this are 2 categories. Who does most of this abuse, neglect, and exploitation? Family, friends, somebody with a relationship with somebody, and then there's the other side of a room full of people like you, except they're professional scammers. And they're on there trying to get you right now to believe that you won the Peruvian lottery. And all you have to do to get your $1 million is give them a couple thousand in taxes. And when you do that, they'll ask for more. They'll ask for more until your bank account is done. They're posing as your grandson who is on a trip in Europe and is in jail. And they're calling you at midnight and trying to wake you up and hoping you say, and they say, Grandpa, and you say, Johnny, and they go, yeah, don't tell Mom, but I'm in real trouble. And people fall for this all the time. So they're doing that right now. So we have all that going on as we try to fight it. So from our work with Wachovia, because I thought the only way to stop this is to go to the source of the bank. So our work with Wachovia led us as the national model for the Financial Services Roundtable, which is the 100 largest financial institutions in the country. And they put out 2 papers based on our program, which we're really proud of. And we've kept, moving in that direction, trying to do that. One of the things I got of that is I got a great partner in Wachovia, one by the name of Linda Mill, who's a senior vice president, who, of course, after we put this great program together for 4 years, and in 4 years, it started in Philadelphia, it moved to Pennsylvania, and then moved to 13 states. Their footprint that Wachovia does They investigated 3,000 cases in conjunction with Adult Protective Services, stopped $2.5 million from walking out the door, protected $62.5 million in assets, and which was a throwaway line for me, which became more important than that, no lawsuits, which is one of the fears of the institutions. We'll get sued if we share your information. We got no lawsuits. The only thing Linda got was emails and cards from people thanking her for saving their lives. Even though they might not have known the people who were abused, neglected, or exploited are 3 times more likely to die, they knew what that does to somebody. If you've ever known anybody who's been exploited or abused, they go down often rather quickly. So that led us to, and Linda's reward for that, by the way, was to get downsized by Wachovia. And so Linda came to work for me for a couple of years before she went to the Department of Aging and taught this all around the state, which was awesome, but she's now back in the financial world with Ally Bank. But we approached Deputy Mayor Gillison at the time and said, you know, we've got this issue in Philadelphia, you know, there's a ton of seniors. So can we talk about this? And we talked to him, and he said, here's what I'm going to do. I'm going to get Mayor Nutter to have a breakfast with all of the major financial institutions in the region that serve Philadelphia. You and Linda are going to talk to them and tell them about this. And he did it, and it was wonderful for us. And he committed the DA and the police to our task force. And from that meeting, we got 2 banks to join us, TD and Beneficial. Beneficial's still on there, TD is no longer on there. But we've grown, obviously, since then. We've added, you know, these guys, as I said earlier, and a whole bunch of people. We have an event coming out on June 15th, which is World Elder Abuse Awareness Day, on safeguarding our seniors. It's going to be a wonderful event. And many of the members are going to be there. And we have handouts in the back, so take that. It's at the Free Library of Philadelphia. I think it's going to be better than the national one, if I have to say so, because we have a caregiver who's not a scam. And that's going to lead off, and we're going to talk about why these happen. So we're going to have Dr. Jason Karlowich from the University of Pennsylvania Healthy Brain Memory Center, who's an international expert on cognitive aging or financial capacity, which are buzzwords that you'll be hearing over and over again in the next decades. And we're going to have a bank working with Homeland Security, and the agent's going to talk about the case. Dana's going to tell you how to solve all this at the end. It's going to be great. It really is going to be Carrie Morgan from the mayor's office. We really have a really dynamite lineup, and we have real live cases, and we're going to walk through this, and it's going to be great. So the major risk factors for this is, as you can imagine, there's a lot of things. There's actually, you know, one of the biggest is just plain old ageism. Number 1 up there, isolation, cognitive impairment. I've mentioned that a couple of times. Health issues and discrimination. So one of the things that has slowed us down and has picked up is the lack of research. Well, there's been a lack of research in this field, but it's picking up. But it's really been a lack of research around the LGBT community, as you could probably imagine. And here's some of the research that we know. A survey in 2001 of LGBT community 60 and over said 65% of people have experienced victimization due to sexual orientation, and 20% have been physically attacked. A 2009 study of the transgender community, 42% of people were victim of physical violence and 80% were verbally abused or harassed. They're outrageous numbers. Further studies said growing up in a homophobic or transphobic environment can lead members to go to extraordinary measures to hide their sexual orientation, and internalizing this can lead to reluctance to speak out and reluctance to seek and accept services. And internalizing that stigma can be a risk factor for self-neglect. So there's also lack of legal protection, which you're all familiar with, and there's some issues that have been rife in the institutional world, you know, including denial of visitors, refusal to allow same-sex partners to share the same room, keeping partners from participating in medical decisions, refusal to place a transgender elder in the room or ward that of their choosing. So this is, you know, it's not a happy thing, but you know, this whole issue is big. But we have, like I said, we have great resources in Philadelphia, as good as anyone, and it's something we can all be proud of. So, I think
Great. Thanks very much, Joe.
I'm Dana Goldberg. As Joe mentioned, I'm a staff attorney at Senior Law Center, and I coordinate a program, Project SAFE. How many people are familiar with Senior Law Center? How many people were here last year or when I came to speak to the, is it Tuesdays?
This morning.
Tuesdays group? Oh, okay, so I'm not repeating myself. Too many people. Okay, so Senior Law Center has been in existence for over 38 years. We are a nonprofit legal services agency dedicated to persons over the age of 60. We run the Senior Law Helpline here in Pennsylvania in all 67 counties. Any person over the age of 60 can call our helpline with a legal question, and free of charge, and yes, that's probably the only time you're going to hear a lawyer say free of charge, they can get some legal advice, they can get referrals to services in their community, and possibly to legal representation. Here in Philadelphia, we're particularly fortunate because in addition to providing the advice, we do actual legal representation, again, free of charge, in certain areas. And we do try to focus on the most vulnerable, the most frail in the older community. So I'm going to go through a little bit of what our services are. So we have a homeowners assistance project. Here in Philadelphia, not only do we have one of the largest senior communities, we have the poorest senior community, but strangely, in our community, many people own their own homes. And a lot of times that's because the home has been in the family for lots of generations. And here in Philadelphia, I think, it's something we can be proud of, that families stay here, even if they go away, they come back. So there is sort of this homestead here in Philadelphia. And so that's good for our seniors. And the other thing we want is we want seniors to be able to age in place. We are not proponents of sticking people away and, in long-term care. And Diane will probably talk about how the movement, although it's been slow, is now gaining traction to provide those services in the home so people can stay there. However, being in the home means that our housing here in Philadelphia is quite old, so home repair is needed, and our seniors are often on a fixed income, so that makes them vulnerable sometimes to contractor fraud, to other people trying to transfer the deed so they can get a hold of that, family members, who may not be on the up and up, and really comes down to money. And a lot of the property here in Philadelphia, there's a lot of equity sitting in that property, so that's money. Anytime there's some kind of asset or money, there's probably somebody out there who wants to get their hands on it. So that's one aspect. We help seniors with property tax issues, real estate tax issues, which has been a huge issue recently because of the increase in taxes in a lot of the communities. So we handle all those mortgage foreclosures. We did a lot of cases in a lot of neighborhoods during the mortgage, or right after the mortgage crisis. There were a lot of neighborhoods with seniors that were targeted for these not great mortgage programs with high interest rates, and it put our seniors at great risk. If you're not a homeowner, we also do landlord-tenant work, and we have a lot of seniors who are renting, and there are a lot of issues coming up, so anytime they have an issue with the landlord, we can answer those questions. We do provide services to represent people in eviction cases where somebody has moved against them, and that actually is in a bunch of different areas. It could be in public housing, senior subsidized housing, or private landlords. We do grandparent, great-grandparent custody work because we are a community where a large number of grandparents and great-grandparents are raising young children in the families. So we do that work. We just started a medical legal partnership at one of the life care facilities here in Philadelphia, which helps to bring the medical community, the legal community, the social workers on site all together and provide sort of one-stop shopping for the senior, which is wonderful. And then there's our victim service program. And for that, We provide advice for any type of victimization, and we do representation in the areas of abuse and victimization. We have some special projects for older victims of intimate partner violence, veterans who are the victims of crime, and then anyone who's been the subject of elder abuse and financial exploitation. We are the civil side. We do work closely with the criminal side, but we are the civil side. Why is it important that we are here? It's important because there are certain things in the civil courts that we can utilize as attorneys to either what I call stop the bleeding, stop the money coming out of the financial institutions, put a hold on the real estate so that it's not going to get sold out from under, which is a big problem. If it gets sold to a third party, there's a bigger problem. And that happens a lot with perpetrators. We work we represent people to get protection from abuse orders, and the important part of that is that if there's a violation, then the perpetrator could be arrested, and also they can be ordered out of the residence so we can create a safe space. Again, for seniors, there is no shelter. There is no shelter specifically for seniors who have been abused or exploited in the city. Okay? And not everyone can go even into a nursing facility or something for safekeeping. The hospitals and the doctors have had their hands tied because of insurance, and they have to kick them out. So we often have a hard time keeping them longer until we can get the perpetrator out of the house. So that's the important part of our getting involved as quickly as possible, using all the tools that we have, including the relationships that we have built up with the police department, with the district attorney's office, with the elder advocates, with adult protective services, and we use everything in our power to put whatever legal means are necessary to protect the person, and then ultimately to make that person as whole as possible on the other end. That's not always possible in these cases, but that is what we're trying to do. Just as I'm sure Diane will tell you, we're in the business of empowering seniors. One of the ways we empower seniors is by coming out here and talking to you, and you are actually the advocates today, okay? I'm here, and the panelists are here to provide you information, but clearly this is not the entire community. So I'm going to charge you with homework of taking what you learned today, the information you take today, and bringing that to those people in your community. It most likely, it's more likely that somebody will turn to one of you to say, I can't pay my electric, I can't pay this, and, I let this 25-year-old move into my house, and now they've been taking my Social Security. More likely to do that. And wouldn't it be wonderful either to have a brochure or know our names or our phone numbers and say, if you don't feel comfortable telling me everything, that's fine. But here's a number you can call to get confidential help. So that's why we're out here today. I hope the scenarios are going to help you open your mind, and I'm going to turn it over to my esteemed colleague, Diane Menio. Thank you.
Hi, thank you. Again, my name is Diane Menio. I'm the Executive Director of the Center for Advocacy for the Rights and Interests of the Elderly. Quite a mouthful. So we call ourselves CARI. How many of you have heard of CARI before? I know a lot of faces here, and I'm even one who worked at CARI. So hopefully the message is getting around about who we are, and of course we are very much involved in launching the EI. So this organization is very dear to our hearts as well. I'm not going to talk a lot about our services, but I will talk about definitely the services that touch on the topic we're talking about today. But I did bring a few materials with me. I brought one, our brochure, so that you can actually see the full range of programs that we have. And also I brought a small booklet about elder abuse. I didn't bring a whole lot of those because it was at the end of the day yesterday, and I made as many copies as I could. But if you want more of those, just let me know when we can get you, we can email them or whatever. And the third thing I brought was not as related to this topic, but it is in a sense. is last week, you might know that the final rules came out for the non-discrimination in healthcare. And it really goes a lot further in protecting the LGBT folks than any other federal law has ever done. It didn't totally, it didn't go as far as maybe it should. But there's still some work, and there's still some, really a lot of this depends on the interpretation. And so I brought some information from a blog that the Elder Justice Now, or I got their name wrong, but anyway, you'll have it there if you pick up one of those flyers. So please do that, because we're talking about elder abuse today, but it also, there's also that institutional abuse that happens as well, and that's what this aims to hopefully fix. And this is part of the Affordable Care Act, and we're just now getting the rules in 2016, and it was passed in 2010. So it's a good thing. It's something to celebrate at least. So please look at that and go look for more information. The links are in there. First of all, just to give you a little bit of history on Carrie, we started in 1977. We were actually started by a group called the Public Interest Law Center of Philadelphia, and some of you may know them. Hilltop is their shortened name. And at that time, they received a grant from the Federal Administration on Aging, and it was really to do advocacy around elderly issues and focused on people who live in nursing homes, people who get home care. The frailest population. Our original name was actually the Coalition of Advocates for the Rights of the Infirm Elderly. And you can imagine why we changed our name. That's not a very... when we said our name back then, and we changed our name in the 90s, early 90s, and when, we'd say our name, people would kind of look at us and do this. No, that's not me. I'm not infirm. And of course, it does, in some ways, describe what we do, because we do try to serve the people who are most vulnerable. But we also are very concerned about giving people information and preventing things like abuse. So, but we also work, the organization was always focused on public policy. And we like to think of what we do as a circle of advocacy, so that we're actually helping people every day through our programs. People call us with a myriad of problems. And I will tell you, one of the reasons that I don't always go into a lot of detail about our programs is because the biggest message that I need to get to people is that you can call us about anything, and we will help you. We don't like to segment what we do. We will help with, regardless of the problem. Han back here was on our staff at one time, helped to get a gentleman who died buried with respect. And an amazing story. I won't go into the entire story, but that's probably not a call we'll ever get again. But it was a very important thing for us to fix at the time that we got that call. So we'll take anything. But we do have some specific programs. But I want to also just talk a little bit about the public policy work that we do. When Joe was talking about the history of elder, of elder abuse and the attention that the national and local and states have given that issue, it was really in the 80s that people started doing something about this, and we started seeing laws passed in other states. And Pennsylvania was, I think, 46 to pass a law. An older adult protective services law. Carrie had gotten a grant. We were able to get a grant from the Administration on Aging in the early 80s. And what we did was with that grant was that it was in elder abuse. And what we did was we went around and set up task forces around the states. And the primary goal of that work was to have legislation. And we got legislation in the late 80s. And after the legislation, of course, any of you who've worked with legislation probably know that it doesn't answer all your questions. You need to continue to work on these issues, and that's what we've been doing all these years. We've done things like, one of the programs that we developed was an education and training program for long-term care staff, because we knew from the calls we were getting that people who were in facilities were subject to abuse and neglect, and they needed an advocate. And they needed to have better care. So if we could train a lot of staff in a room like this to provide better care, and we actually had some really wonderful results. We worked with a researcher who was able to look at at pre-test and post-test information after our training, and we actually had a big impact. And that program, at this point, has been replicated in almost every state in the country. and about 3 or 4 foreign countries. So we're very proud of that program, and that's part of what we do. We like to think about, what can we do to have the broadest impact we can, because that person who calls us on the phone is one person we can help. But if that person calls us and they give us the kind of information we need to know that we can go and talk to regulators or legislators and make a change that can help hundreds more, and maybe it's just calling like a healthcare, insurance company. We had a case back when, if anybody knows what Health Choices is, in the Medicaid program, when Medicaid went to managed care, there were a lot of problems in the beginning of that program, and one of them was that a lot of our older adults who were on Medicaid, as soon as the cost of their care seemed to get expensive, they cut it off. And so they ended up in the nursing homes. We had this daughter call us because her mother was she was in hospice and she needed oxygen, in-home oxygen. And of course, she and her mother both wanted her to be able to die at home. And the insurance company said, oh no, we won't cover in-home oxygen. She'll have to go to a nursing home, which of course costs the state a whole lot more money. And it wasn't what the family desired. So we were able to actually fix that one with a phone call to the state and a phone call to that insurance company, and no one ever got denied that kind of service again, because those were actually things we were warning them about when they were doing this. So that's what we do. We try to have an impact on how services are being provided to many people, and so we try to make sure that our impact goes on. I want to mention something that we do. We have a monthly meeting. It's called our legislative committee. It's called the Dorothy Washburn Legislative Committee, named after a very wonderful woman. That committee meets on the first Thursday of every month, and it's a wealth of information. If you want to get information, you don't have to come to the meetings if you don't have time to do that, but you can get information about legislation and then things like that, many different issues that you can learn about as well as participate in. So if there's something that you care about, like for instance, the non-discrimination in healthcare. When that rule came out for public comment, we made comments on that, and we shared that with our committee and those who are involved with us, and hopefully they were able again to take our comments or to at least make their wishes known. And so that's the way. So if you go onto our website, you can sign up for our monthly mailing, email, and also attend our meeting if you wish. Joe mentioned the Elder Law Task Force, which is something that was set up about 3 years ago. It seems like, time kind of flies, so I don't even know. By the way, I've been at Cary for going on 28 years now, so that's why sometimes my memory, I go way back and I tell you stories from long ago and from yesterday. And so the Elder Law Task Force was set up by former Chief Justice Castile with Justice Deborah Todd as the chair about 3 years ago. And this was the first time that we had a group that was really focused for a good concentrated period of time on elder issues. And the two issues that we were primarily focused on is elder abuse and guardianship. Those are the two issues that we examined very carefully. Took over a period of about, I want to say about 9 to 10 months, almost a year. We had separate committees. We had I think 46 members. We had judges, we had DAs, we had lawyers, we had a couple non-lawyers, me being one of them, and people from the administration there to provide input. And so that this group came up with about 135 recommendations. And a lot of them, because it is coming from the Supreme Court, have to do with the court, but we divided those up. Some of them are legislative initiatives, some can be done by the Supreme Court. But one of the big things that happened, one of the recommendations was to have an office of elder justice in the courts. And so that was set up by Justice Todd and is now operating, and I'm on the advisory council for that particular department, along with about 16 other people. And so we've been working again on our big charge is to make sure that those those recommendations are moving forward, and that's what we've been doing, and we've been doing that for about a year now, a year and a half, and so we continue to work on that. But that's the other thing that we do. We get involved at the state level. Most policy most policy is at the state level. At the local level, yes, you have some impact. You know, we have PCA has a public hearing on Tuesday, so you can go and tell PCA what you think about their plan, what you think they should be doing over the next 4 years. And we will be doing that, but a lot of our public policy is really at the state level. That's where the money is, and that's where you need to be. So that's what we do. I just very quickly also, I know my time's running out, and I'll probably get to say a little more, but we do have, I just want to very quickly mention the programs that we have. We do have a program where we actually accompany people in court in Philadelphia, older adults who've been victims of crime. As a part of that program, we also do some emergency security work on their homes, so that if Dana does a protection from abuse order on maybe a mother needs to keep her son out of the house or her husband out of the house or whatever, but they still have the key to that house, and the vulnerable woman can't get the police there quick enough to be safe, and so if we change that lock, they try to use their key, they can't get up. There's time for the police to get there and protect that person. So we do that. We also, we do it for other purposes as well. Certainly if someone's been a victim of, we've had people who have their keys stolen, and then we've got, along with their from their pocket or whatever, and then we have, we can secure that home so whoever has a key and their ID can't get in. So, that's one of the things we do. In that program, again, we will help people with whatever needs they have. The other program you might be interested in is our long-term care ombudsman program, which is a program, it's actually a national program, and it's in every place that you could go in this country. It's a program that helps to protect people who are in long-term care. And so basically, we're the advocate for that individual. We don't have regulatory authority or any kind of that kind of authority. We use those agencies that have regulatory authority to do our advocacy and hope that they will do their job. And actually, some of our time gets spent trying to get them to do their job better. And so that's on our more systemic work. But we spend a lot of time trying to help improve care. And when someone has a problem, we'll go out and see them, or whatever ombudsman program is covering them should be doing that. So those are just a few, and I know I've kind of probably already run over, but I'll be talking to you some more. Thank you.
Great. Thanks, guys. Thank you guys so much for having me, David and Joe. Thank you for inviting me. I certainly think in Philadelphia we're really lucky that we have so many good resources. PCA, Terry, Project Day for All, really, really good programs that we have. I think as a geriatrician, my perspective on this is our role is the person in the community who you know well as the person who's taking care of you. We can help you find these services if you do need them. I do think a lot of times the ways I've been able to find this in my practice have been patients who are pretty good about coming in to see me every couple months and then for some reason stop coming in. Someone who stops taking their prescriptions. Someone whose blood sugar is suddenly out of control, someone whose blood pressure is suddenly out of control. And those are things that kind of trigger me. Poor hygiene, poor bruising, strange relationships with family members. As these guys were talking, I had a couple of instances that popped in my head. I had one patient who was a really active older man who came in with his son who I hadn't met before, but suddenly started coming to his appointments, and the patient stopped speaking like he used to, and something wasn't right there, and he said that he was moving into his house, and something from that triggered us to call PCA, who went out to the house to help us, and certainly PCA is our first line of protection. We're on the phone with them whenever there's anything concerning. I think one of the big things out of all of this that I'd like to give a plug for, and I'm sure the case scenarios will have us having some more conversations about stuff, but certainly getting together your living wills is one of the most important thing I think you guys can do, is having somebody who could speak for you if you can't speak for yourself. That's the most important thing, because I know it's not always going to be the person who falls in your surrogacy list who would be your parents, your spouse, your children, and then other family members. So really important to designate somebody who can speak for you on your behalf if you can't. And that's one of the most important things I think that I run into in the hospital all the time. People not having their paperwork together, and certainly I can help you at the office, or somebody from one of these agencies could certainly help you with that, and I think that that's huge. A little plug for our office as a community community resource. We're over at 834 Walnut Street at Jefferson, so it's a few blocks away from here. We see patients 55 and older, and really our specialized care falls, and we do comprehensive geriatric assessments. So we look at how likely is somebody to fall, how complicated is somebody's prescription regimen, how dangerous is that. We have a pharmacist on site who can help you with your medications. We actually do in-home visits, so if you're concerned about your home being safe because of falls and things like that, we can come out to the house and help you. And a lot of times we've actually found patients who in their home are self-neglecting or have family members who are exploiting them. So home visits is a great way we can help you with that. We also have telehealth visits, which is something as people are getting more technologically savvy. We have a program called Jeff Connect where we could see you over the phone, and it's a little bit easier than having to come into the office. So certainly a resource. I have some flyers in the back for our office, so we'd be happy to see you there and help you guys out if you need anything. That's all I got.
Into our scenario phase. We've had a few examples, but the members of the panel and some of the other people organizing the presentation kind of came up with some examples that would involve, individuals and certain situations more specific than what we maybe have talked about so far. Okay, so the first one is Dana's. These are in your packet. You have your scenario, Dana?
What?
You're first.
Oh, okay.
I faced this scenario, kind of took a couple of actual cases and brought them together. And this is a story about Joe, who's 75 years old. And, the biggest thing I get, and I get it from my own parents, is, well, this could never happen to me. I'm educated, I had a great career, this, I would never fall prey to anything like this. And, I've talked to them till I'm blue in the face, I do this for a living, and they're just adamant. So I want you to know that Joe was a pretty, big part of the community. He was a business owner for many, many years. He owns his own house. He is on a fixed income at this point from savings and Social Security, but most seniors are, okay? The longer you live, not everybody has unlimited means. About 5 years ago, Joe began having some memory problems, and other people were noticing this. Joe was noticing it. He did downplay it a bit, okay? And his doctor did inform him that he was suffering from, and here you go, mild cognitive impairment, okay? And so that, I put that in there because I do have a thing with my friends who are doctors about what that means to those of us who are not doctors, because there is that little word, mild, in the front, okay? So, Joe is a gay man, and, just like a lot of men his age, unfortunately, his family relationships had suffered. So he had not really had siblings or family members involved in his life. He has been in a steady relationship for 20 years. And the one thing you have to know is that as you get older, well, I don't have to tell you this, you know this, but as you get older, it's not like we don't want to be intimate with people, we don't just cut off and stop that part of who we are. And in addition, actually, sometimes people with dementia, cognitive impairment, that actually can get enhanced, okay? So there is this physical desire for other people. That's a human nature. And so Joe went to what now people do. How do they meet each other? They meet each other online a lot of times. They don't always go to the bars or other places. He went online. And he meets this guy, Gary, and they talk. Gary's 24 years old. He ends up going to meet him. And they form an intimate relationship. Joe's house needs some work. Gary says, I'm handy, I can help you, Joe, let me come in, I'll do this work for you. And Gary says, but, Joe, you need to pay me. I need tools and some other stuff. And what really gets it is that it turns out that Gary keeps asking for payment for the same things that happen because Joe can't remember what got done, what he paid. I will tell you, he was making some notes, but it was like all over the place. They weren't dated, so he never knew what he had paid him. Gary begins to show this other side when Joe would say, I think I paid you, and he began to get threatening. And it began to get scary. And Joe kept vowing not to have anything to do with Gary. Friends would say, I don't think you should see this guy anymore. I don't think he's a good guy. A couple weeks would go by, Joe would become lonely. He's not really seeing anyone, other people are active, he's not as active. And either Gary would call him or he would reach out to Gary and the whole pattern would start over again. So it went on for a couple of years. Joe lost about $20,000 in savings, and we're at the point where Gary is pushing to become Joe's representative payee for Social Security, meaning he's going to get the Social Security and he's going to be in charge of where that money goes, okay? Gary also began to press Joe, because he owned his home, well, you have repairs, I think you should look into a home equity loan or a reverse mortgage, and he began to push Joe at this point. So that's kind of where we are at this point. Joe comes to our attention through some people that cared about him. And it was at this point that we had to discuss with Joe making some decisions. He was frightened. He was scared of Gary. So with him, we did file for a protection from abuse order, okay? Joe, at this point when we filed, could still remember the incidents, okay? I will tell you by the time, because court, you file in court, and we did get a temporary order against this guy coming to the house, but the problem is nothing's fast. So by the time we were scheduled to have a hearing, we were several months gone. And his impairment started to go downhill big time. And I think one of the things that the doctor can probably talk to is stress is not good when you have any kind of dementia or impairment. And he was under a lot of stress, and he was scared. So he actually began to go downhill big time. And I was really concerned about the fact that he wasn't going to be able to testify about what had happened because he couldn't remember what was happening. We were able to get to Social Security in time to block any access to a third party. And he did come to us in time that we were able to make sure that his personal planning documents, so that would be his financial power of attorney, his healthcare power of attorney, his will, and his living will. We had to get that done very fast because of his medical condition to make sure that he had a chance to choose somebody. I will tell you, in certain cases, they come, seniors will come to us, and already they've put Gary on as that agent. And so it's important that we immediately revoke those documents so that they can no longer go to the bank or Social Security or the Veterans Administration to get that money turned over to them. So that's kind of where we were with Joe. The sad part about Joe's case is that although we were able to stop all of these things and he was able to do his documents, he still was really lonely. And he was still really isolated. You know, a lot of his friends had died and he didn't have these family members involved. And it came to my attention after we did all this work that several months later, he recontacted Gary. So I'm putting that out there because one of the things why we're here in terms of community, and the other panelists can talk about, but as a lawyer, I can do certain things, you know, to empower the senior, and we can, you know, put all the documents, we can let the bank know, but there's a human aspect here too. As a community, how many of our members are not hooked into a support system? You know, how many people are looking or are prey to people who know they're vulnerable, you know, and have no interest in the well-being of that person whatsoever. But they need that human contact. They're craving that human contact. And that's a big factor in making you vulnerable to any type of abuse or exploitation, or even keeping you in some sort of relationship. You know, if that's your only person that you have that you see every day, are you going to want to cut off that lifeline?
Okay, thanks. And do your other panelists, we want to get everybody's scenario. Have anything they want to add to that scenario, or how they might have intervened or
Well,
helped?
you know, and certainly, you know, if that came to us first, we'd probably be referring to Senior Law Center for some of those, some of the things they did. But the other thing that we would do, I mean, and if there was a court proceeding, we'd be helping that person in court possibly. But what we do is our advocates spend a lot of time with people when they go through this. And so we'd be trying, and it's not always successful, but we'd be trying to connect him with other networks and resources. If he's able to come to the William Way Center, for instance, we might refer him here, so that he could get to meet people and feel less lonely. I mean, if that's what brought him to this problem, we should be trying to address his loneliness in one way or another. Maybe there is an option. Maybe he lives somewhere where it's not even feasible for him to be coming to a center like this, but it might be another center. It might be some other way to connect him with services. And the other thing that we would do is to make sure that he was getting everything that he needed. So he might, from the scenario, it's not clear if he has issues, other issues, like if he isn't adequately able to make his meals, for instance. Does he need meals on wheels? Is transportation an issue for him? Is that part of the reason he's isolated in his house? Maybe we can help set him up and understand what options he has for transportation and advocate for him in that way. And there may be other services that he needs that we can help him get. So that's where we would try to be on this, to try to prevent him from turning back to Joe. Is it Joe? Gary, every time that he needs companionship. It is challenging, as Dana said, because we see this happen with people again and again. They go back to the abusive relationship. They go back to somebody who's exploiting them. And it's become more and more challenging for us to understand that, for the physicians who are doing this research to understand why people keep getting scammed, for instance. How does that happen? Why? And there's a lot of research being done right now at Cornell Weill at University of Pennsylvania to kind of look at the brain and figure out why are people making these decisions. And in some ways it's kind of scary to me to think about that, because I'm a little worried that if I have this loop in my brain that they're going to start wanting to take over for me. And but technology is moving, and hopefully we'll be able to understand at least more about why this is happening, and hopefully that will lead us to ways to fix this.
Great.
I have a quick comment on one thing Dana mentioned was mild cognitive impairment, and what that is basically it's somewhere in between somebody with normal cognition and somebody who is diagnosed with dementia. One of the things we would do in my office would do something called a geriatric depression screen, and a lot of times people who are having some kind of psychological distress, whether it be anxiety, depression, isolation, loneliness, that could sometimes end up turning into some kind of cognitive impairment. So that would be something we'd want to see. Is there some kind of counseling that we could find for somebody, or some kind of medication we could prescribe for this that could possibly help this? So that's something I would say we can help with.
So if this continued to go south and the mild cognitive impairment blew up into full cognitive impairment, then if Dana still had it, she'd refer it to me. If not, we'd count on the community to refer it to me, and my investigators would go out and take a look at that. And in case Gary now had the rep payee all his own, we can take steps to get that back. And unfortunately, for the most restrictive would be a guardianship, and we go to the orphans court and get guardians and get someone else appointed to handle the money. And as everybody said, it illustrates that the twin peaks of isolation and cognitive impairment. We're talking about the studies and why people keep falling for these scams, and one of the ones that opened my eyes and keeps me awake at night also is a study been going on in the University of Iowa for a few years now that say normal aging of the prefrontal cortex can lead to reduction in skepticism and increase in gullibility. So that's the daily double. And then you get the call that says, you just won the Portuguese lottery. As I said, although you've never played it. And all you need to do is give us a couple thousand on your taxes, and then you keep doing it until you're broke. So we worry about that. But I would step in at that point if it continued to go south and take necessary steps.
Great. Okay, thanks. Diana, you've got a scenario.
Okay. Before I move on, though, can I just ask if anyone here has any comments or questions about this particular situation or anything else?
Yeah, we'd like to keep this.
No, okay, I just wanted
Have
to
a
see if there
chance.
was, I just wanted to see if there were any comments.
Okay, thanks.
Okay, but since there aren't any. Okay, well, we put together something, I think this is from 3 different situations, but I didn't want to have anything that was identifiable. Morris is 79 years old. He went into the nursing home after the death of his wife. She was his primary caregiver. He has 2 sons, but they're busy, and they weren't able to move in or have to move in with him, so he ended up in a nursing home. He has multiple medical issues, and he also was diagnosed with mild dementia. And his sons feel that he's declined more since his wife died, and since he moved to the nursing home. And what they notice is that his state changes from during the day. Probably he's having sundowning or something, but anyway, he changes from time to time. Sometimes he's more able to converse with them in a reasonable way, other times not so much. He's become close to his roommate, Jim. Jim's 84, he has Parkinson's disease. He's been in the nursing home for about 3 years. He's been estranged from his family for many years. He had no other option than to go into the nursing home. His partner died, precipitating his nursing home admission. And his partner was the homeowner of his house. When the family came in after his partner died, they basically evicted him from the home. They didn't want anything to do with him. And so he had no other options. And so a few times, or at least 2 times, Morris and Jim had been found in bed together by staff. Morris didn't seem distressed at all. He seemed to welcome the relationship with Jim. However, after, when they tried to talk to him about it, he doesn't seem to remember it. And so, when the staff, which they're required to do actually, when they have an incident, they notify the sons. The sons were very angry. They wanted Jim moved to another room, and they're threatening to sue the nursing home. That's just a little extra information. But I would rather, I don't want to talk too much about this. As I said, it's about 3 cases, so I can tell you what we would do. And this is the kind of thing that might come into our ombudsman program. It might go right to Joe's office. It might, go to the police. We don't know. I can tell you that if it goes to the police, nothing would get done. And no, it's seriously, nothing. Many cases of even cases of violent sexual assault in nursing homes, we're not seeing anything be done by the police. And that's a big challenge that we have, and we're trying to advocate for better response on that level. So, but in this case, I think it's a little more gray. And Doc, you want to take this?
Yeah. It kind of triggered me to think of that case that was a few months ago that was in the news a lot. I don't know if you guys saw it. There was the man whose wife was in a nursing home. She had some dementia, and he would go visit her, and they would have sex. And her doctor at the nursing home, wasn't that crazy?
Yeah.
Her doctor at the nursing home called the cops on him, and he was being accused of rape. He was cleared of rape as of now, I believe. Is that right?
Yeah. I believe so.
But it's definitely a problem that we see, and I think the thing for sexuality in people with any kind of cognitive issues is making sure that both partners have the capacity to be having intimate relations. The concerning part here is that Morris doesn't seem to remember or recall. That to me is a little worrisome. I'm not sure if he has the capacity to be having sexual relations, but that would be the one thing we would want to figure out before then. But certainly a concerning situation.
And my question back to you is, and this is something, I actually had another call that's somewhat similar to this, not quite the same. But the other question is, if there doesn't seem to be harm here, and what we're getting into is really an ethical discussion, and I mean it's also could be a legal discussion, but it is an ethical discussion often. And so, how do you make that determination that even though because obviously he's able to do certain things, I'm assuming he can dress himself and he can do certain things that we all do every day, and the fact that he doesn't remember, there's another question here about the doesn't remember thing, is that he doesn't want to talk about it, which is a totally different issue. And so we have a man who was in a heterosexual relationship, and now he's in a very different kind of relationship. So how do you work through this?
Yeah, certainly it's a really good question. I think it's a case-by-case basis, obviously. I think, like you said before, is making sure that there isn't any harm. And it sounds like Morris isn't bothered by this one way or the other, so I don't think there's much harm there. A couple of years ago, I was working at a nursing home out in the suburbs, and there was a patient who had some cognitive impairment, who his nurse found him and he was masturbating, and this made a big to-do. He was masturbating and he was acting out, and his nurse was all upset about this, and she wanted to prescribe him Haldol for his psychosis because he's masturbating. And I said, he's an 80-year-old man who's masturbating. God bless him. Let him masturbate. That's wonderful. And so, I think it's very case by case. It's going to be facility by facility, but I think it's a matter of making sure that there isn't harm. And so if somebody's sitting there masturbating, he's fine, I don't care. And so I think that's kind of how I look at these situations. If someone's not being harmed, I probably would look the other way and not really get involved too much. As far as lawsuits go, I don't know if you could speak more on that.
That's a little bit of a thorny issue there.
Yeah.
I will say that the other initiative that the federal government has had for a long time, and for at least a few years now, is reducing psychotropic medication. So in that case, putting somebody on Haldol because they're masturbating would throw their numbers up. They might not like that.
Okay, so from a legal point of view, one of the things that happens sometimes because we run a helpline is one of the sons might call our helpline, okay? Now, first of all, you have to be over the age of 60, for us to speak to you and give advice. The other thing that we do is we do an extensive sort of intake in terms of who the person that's calling, because in this particular case, The senior is Morris. So our job as lawyers is to identify who the client would be, okay? And the client is the senior themselves, okay? So that would be Morris. So what we always insist on is, well, we have to speak with Morris. And then as lawyers, we have an obligation to determine whether or not that person knows who we are, whether they voluntarily want to speak to us, whether they do have a legal issue or concern. If Morris is, so far into the throes of dementia that he doesn't know who we are, I mean, we're not going to be able to establish a relationship as an attorney-client, and so we're not going to give any advice in this particular situation. What that means for Morris, though, is that could be difficult. Let's say that it wasn't consensual, okay? Then that could be difficult because who's going to be that person's advocate? And that's how that comes up. But if Morris, and I do pride ourselves, when we speak to people, it is about creating that confidentiality, that trust relationship, so that if that was what was keeping Morris from, asking the question, hopefully, he would feel comfortable to say, well, I'm just scared about telling the people here at the long-term care facility that, I really want to be in this relationship. And then we could be able to counsel Morris in terms of, just because you moved into a long-term care facility doesn't mean you can't have relationships, okay? And there may be questions in terms of then his asserting his rights with the nursing, the long-term care facility, in which case maybe the ombudsman would be a good person to help with that. Or maybe they need to talk about the ombudsman that maybe both of them don't want to stay in that particular facility, and what options do they have? So these are the kinds of legal questions that will come up. It could be the social worker who calls, with Morris and reaches out for that. So there's a lot of different ways that we may get contacted, but what I want to stress under this scenario is, as lawyers, our client is the senior. That's the person that we are advising. So just because the sons are calling irate because of this relationship does not mean that they get to avail themselves of our services.
So most of the issues have already been touched on what we would do, and so it would come down again to the capacity to consent. And in 1995, we had an amendment to our act, the abuse of a care-dependent person, and that includes sexual abuse. And so in my experience of getting these since 1995 from the facilities, if we would get one of this nature, they would already have taken steps to separate people and calling it in because they have to call it in. And we would go out and it would again depend on the capacity of the person to agree or not agree. And I think we covered that.
I just want to finish up with, this is the kind of call we do get in the long-term care ombudsman program. And we would also, the person that we work for is Morris in this case, unless of course Jim called us. And then we might work for Jim because they're trying to move him to another room. There are a lot of rights that people have when they live in nursing homes, fortunately for them. And one of them is that they can't be moved against their will, and so if there's no good reason for it. So we would, if this were a situation where the facility was more concerned about the liability that they had than they were about these two guys, and Morris was able to communicate with us and said, I like Jim and I want to stay in this room. Maybe he didn't want to talk about the relationship so much, but he said, I like Jim. I really, I want to stay in the same room with Jim. We would fight that move. The other thing is that if Morris did not have as much capacity, if he were somebody who didn't have capacity, his sons were, insisting that Jim be moved, we'd say, no, move Morris, not Jim. Jim has a right to stay in his room. So there's a, you know, a number of issues here, but yes, you know, we'd be out, we'd be trying to advocate on behalf of the person who called us. And that, you know, and especially if he's able to communicate. And if he has mild cognitive decline, he probably is going to be able to talk to our ombudsman and give us permission to work with him. So we would do everything we can to make sure that this is resolved.
Okay, great. Next, we have scenario number 3, and that would be...
Okay. So in this scenario, Mary is a 70-year-old lady who's been with her wife for several years. She doesn't have a doctor who she sees regularly and tends to stay away from medical care. She shows up at the hospital with pain in her wrist. She's admitted, and the x-ray finds that she has a fracture. She tells her doctor that she hurt her wrist and tripped over a box in her living room. The physician who sees her, this is his first time meeting her, so they don't have an established relationship. He doesn't know anything about her. This is the first thing. She does share with the physician that she does have a partner, but the partner couldn't come to the hospital. Mary doesn't want her wife to be called. I guess one of the things here is there are some potential red flags, but to be honest with you, I actually didn't put this case together. But to be honest with you, I don't know that if I was the doc in the ER seeing this patient, I don't think I would do anything about this. I think I would treat the wrist, and that's it. This is a classic. If there is, underlying this, there's this implication that there's some kind of domestic violence going on. From this scenario itself, though, if I was seeing her as a patient, I wouldn't jump to that conclusion. I'm only thinking of that because of the context of what we're doing today. But certainly, anybody who comes into the ER with some kind of injury that is concerning, we can't do anything about it unless the patient wants us to. So if the patient says, if it's a clear-cut, battered wife, black eye coming in, we can't do anything if they don't want anything to be done. And a lot of times, if we do intervene, we can make the situation worse if there isn't a backup in place to protect the person who's being abused from the abuser. And so it puts us in a tricky scenario as the physician because we could have this concern all the time. It's very different in children. If there's a concern of a child being hurt in some way by their parent, by a sibling, by somebody, we can take them out of the house. When you're a person over 18 years old, you have the choice to file something and you're able to make these decisions for yourself. So unfortunately, in this instance, I don't think there would be much I could do other than treat the fracture of the wrist.
Yeah, and I think that, you know, Joe talked to you a little bit about the criteria for protective services, and she seems to be very well able to make her own decisions, and that would be it would be challenging if you did make that report for them, and Joe can talk about that. But the other issue here is that we had talked briefly before the program about mandatory reporting, and physicians are not required to report this. And so when we were passing the law that passed Act 13, I always get the two mixed up. They were passed at the same time, Act 13. Originally in the legislation, docs at hospitals were supposed to report, but the lobby took them out of that. So they're not required, and I think in this case it's probably good. And the other issue is that I think there are ways to know whether this is abuse. You know, the broken wrist, you can fall, you know, it's easy to break a wrist, I think. And so whether it's to see finger marks or whatever, you know, there are some ways to see, and if she returned, maybe then you'd be starting to look at it this differently.
So there's a couple things I wanted to bring up here is that access to information in the hospital. Okay, so you go into the hospital, there's a lot of information, you know, there's usually the cards just for domestic violence and to call the hotline. And so certainly, you know, that's available and that's there. What is growing but not quite as prevalent is the information for those who are older adults and what those resources are. And the reason I say that is because if Mary were to call the domestic violence hotline, okay, So they're going to go through a lot of series, scenarios and safety planning and all of that. However, some of the safety planning for older adults is different than it might be for younger adults. Okay, let's say that Mary has a severe diabetic condition, and then maybe she has some other health concerns. Okay, she left the house to go to the hospital. She doesn't have any of her medication. She doesn't have any of her prescriptions. She may have left without any ID. Is the domestic violence shelter, if she needed to go there and she was willing to reveal to the doctor, going to be able to care for all of her needs? What if Mary's wheelchair bound? What if she's incontinent? There's a lot of different scenarios I can put in this place. What I want to stress to you is that we only have 2 domestic violence shelters here in Philadelphia, and they are not, they're great and they're wonderful. They're in high demand, so there's usually a waiting list, and they're not set up to deal with all of these conditions. Okay, so that's the first option. The other thing is here, we're dealing with Mary, but if Mary was Stephen, there's no shelter for a male domestic violence victim, okay? So then the doctor's left with, where am I supposed to send Stephen if Stephen says that? There's the other concern in terms of who's communicating with whom, okay? So Mary goes to the ER, and she's seeing a doctor there, but is that doctor communicating that night with a regular doctor? Does she even have a regular doctor? Maybe she doesn't. Maybe occasionally when she's getting beat up, it's, it might not be every week. It could be every few months. There's a different doctor on at the ER. Who's putting all of the pieces together? What we've been doing is trying to educate the social workers, the caseworkers, the people doing the discharge and the care planning, to sort of have those conversations, provide older adults who, with that information of the different organizations in the older adult community, so that they can, if they need to safety plan, we're looking at all the different options that we have, okay? Legally, yes, if Mary was in a situation, we would want her to know there's a 24-hour, 7-day-a-week, 365 days a week filing for a protection order in Philadelphia. But here's the other thing. Let's say, in this scenario, that's her wife. Let's say they weren't married and she doesn't feel comfortable saying that that was her intimate partner. If she doesn't do that, most likely she will be denied an order, because you have to have certain types of relationships in order to get that order. And that's the only way to get that immediate relief of having the partner removed from the property. So that's another issue. I do think there are lots of judges, and I just was in court last week, and one of the parties was transgender, and I was really, really happy to see how the judge interacted with the party in terms of being very aware of the language that was used, any kind of lifestyle choices, not being judgmental, all of that, which is a huge improvement from when I first started going into court 24 years ago. So there is education. Unfortunately, there are a lot of people on the bench who are not so educated, and, can I say that Mary wouldn't have a bad experience? I can't promise that. There is still a lot of ignorance out there, so that might be something. Having those resources and coming to somebody where, they can get the support, the information, maybe have somebody go to court with them, all of that is something that's going to help support the individual and help them to be in a situation where they could make a choice to get out of the relationship and get safe if they choose to do that.
So we're also open 24 hours a day, 365 days a year. I don't think I've given the number today, 215-765-8785. 9040 and then press 1 for protective services. And this case for me would come down, I don't have any, there's no relationship barriers to getting services from me. The barriers are, is Mary over 60? Does she lack a responsible caregiver? Is she unable to help herself? And is she at imminent risk? And possibly 3 of those could be right there, and we would have to work out the 4th one. Is she unable to help herself? So that would be depend on the quality of the report and the quality of the intake taken. So if we get the intake that says she's scared to death and she can't do anything, she's frozen with fear, we can go out there. So she can be eligible. And then it goes down to what we always do. You know, and you know, we come and knock on the door and speak to Mary and hope to speak to her alone. I would love to always go out with 2 people, but I don't have enough funding to do that. We're going to get probably 3,300 reports of need this year in Philadelphia of abuse, neglect, exploitation, abandonment. Remember, 1 out of 24 doesn't get reported anywhere, so imagine how much that is. And I tell my people all the time, you know, this isn't normal to have somebody come up, hi, you didn't call me, but here I am, and can I talk to you about what might have happened? And by the way, can you sign this release? So I can also look at your financial records to make sure you're not being exploited. And it doesn't go like that, of course. But that's at least I don't think it does. And so that's the hard part. But in a lot of these, we can get in, and we can go in, and we can offer the services. And in these relationships, it's hard to make the decision to leave. And people change their mind often. So my folks will go out there and get everything, protection from abuse or for a call back, and they'll say, I changed my mind. Or the alleged perpetrator will pick up the phone and say hello because they're back in. And I say to my staff, I've said it for 20 years, you're not failing because what you're doing is you're planting a seed that it doesn't have to be this way, that there is an alternative. And even if they shut you down, they may remember a year or so later, there was this nice young lady, and I said, you lady, because 39 of my 42 staff are women, that come in, and all the men are named Joe, by the way, for some reason. And so, you know, they planted that seed that somebody else can come out. That nice young lady that came out told me there was another way. And, you know, I don't think we have any research on elderly men or women, but the research on domestic violence says it takes someone 7 times to make that decision to leave. So I'm guessing, without doing the research, it'll take longer, specific to the length of the relationship and all stuff like that. So this could be for me, or it could not even ever come to me, or I could shut it down at the door saying, this is a no need for protective services, let me give it to somebody else.
Thanks, Joe.
So can I add just one thing? So I did want to add that even with educated professionals, I think there is a notion when they have people coming from the LGBT community, well, women aren't violent. And I did want to address this here because I think there's a tendency to say, oh, what are you talking about? Your partner, could never, that doesn't happen. And first of all, it does happen, okay? And it happens across all age groups in lesbian relationships. I do think that the women will tend not to come forward for a lot of different reasons, even more so than the men. But I did want to bring that up, that I do think that that's out there, this notion. What you should know is that the vast majority of perpetrators of elder abuse are women. Okay, and that could be adult children, it could be other family members, partners, but the vast majority, I think it's like 80%, are women. And they're harming other women, they're harming men. So we have this notion from society or whatever that women can't be violent, but clearly the statistics are telling us differently. What I would like to see, and I don't see so much from the lesbian community, is, I see even less people reaching out. And, I think that is some on our professional side, that we have to get over that notion and understand that violence is everywhere. And we need to be open and encouraging everybody to come forward if they want the resources to be able to change that situation.
Good point. Thank you. Okay, Joe, you've got the last scenario, so let's move on to.
Okay. So Sophie is, this is a classic scenario of possible self-neglect with a little bit of possible financial exploitation mixed in, because, even though I said in the beginning, physical, emotional, sexual, self-neglect, caregiver neglect, financial exploitation, they don't come like distinctly separate all the time. They come in the terms that we use now as poly-victimization, and so they come together. These are all possible. Sophie is one of those folks who was part of a unit, always did everything together, always were seen together, the less social of the unit, and now after the death of her partner 10 years later is starting to withdraw from the community that she was part of. And after a while people just let you withdraw and you stay in your home. And then they started noticing less and less the lights were on. We had the summer heat wave, the air conditioner's not on, there's something going on in there, and somebody go in, and they also noticed this other person starting to show up. And so are we talking about Sophie being depressed or demented or self-neglecting? Are we talking about a third person taking advantage of the possible depression and getting a hold of the money and going in? So again, one of the things we need, and that's why it's tremendous that you're all out here, we need somebody to call us. All of us do. So I need somebody to pick up the phone 24 hours a day, 365 days a year, and call and say, if you have reason to believe that something may be going on, you pick it up, you give us a call, and in this case, it would be one that we would show up at the door, and again, knock on the door. Now, we have a code of ethics in adult protective services, and, the code of ethics starts with every adult has the right to be safe, every adult retains their civil and constitutional rights unless taken away by a court. So, we are at the same time the protector and the advocate for the older adult. So we're going to knock with Sophie, and we're going to go in, and we're going to hope that we gain the rapport. This may take a couple visits to have Sophie open up to us and let us help her and let us look at the bills and let us, make an arrangement if she can't do that before, or if the new visitor is taking over the bills, let us, get that authority to somebody else, and let's get the lights back on, let's get the utilities on, let's get everything working again. And again, it's never quite that easy. It's 1 out of 5 people, and I haven't done this, I did this for maybe the first 5 to 6 years of my practice, but 1 out of 5 people that we said, okay, you're eligible, told us then to take a walk. Because Sophie can stop us at the door. She can refuse to open the door. She can tell me to go away. She can let us in and change her mind like she did for the neighbor. And so it's a question we always ask, why would a person open up to a stranger who, and we, unlike the rest of PCA, most of PCA, I work under a law, the Older Adult Protective Services Act, that tells me when I should act, how I should act, what I should do, and within that is the varied skills of the investigators that I send out there. And so they're all really good at getting in. It's one of the remarkable things of the program that I say all the time, and I think it may change with the baby boomers. I've been predicting this for a long time, because my staff is very excited to see which one of them gets a report on me in a few years. And they really are pretty excited about it and thinking, I want to do it, I want to do it. And I'm like, well, none of you are getting in. So I don't know what you want to do. They all know where I live. None of them are getting in. I have a plan, and no violence, but I have a plan for each of them. And, it's what we have to do. They have to get that rapport first and get in the door and show the empathy and let me look at these up. And if they're in a bad place, we can help. And if she has capacity, just depression, and needs some legal advice, I'm going to call Dana. If the capacity is gone, then one of the other things that we have, and other programs have that, but we have in Philadelphia, I have psychologists and psychiatrists who do home visits for me and give me a psychological evaluation that tells me if the person can still make decisions about where they should live, manage their money, and medical decisions. So that would involve us getting the psych eval, going to court, getting somebody appointed, and taking care of all the issues. So, again, that's a 1, 2, 3 connect the dots. Boy, do I wish they went like that. all the time. Some of them do. Again, like I said, all the time, it's remarkable to me that for years, we knock on the door and people just open up and let us in, which is kind of disturbing in one way, but in another way, it's good. We're able to help with the person who's eligible for services, and if not, of course, move them on to somebody who can help.
Okay, so if Sophie does not reach out to us, okay, then we're not going to be involved. How we often see these self-neglect cases are actually not necessarily to my program. They're intake because there's an eviction case, like a landlord-tenant case. Sophie may have been hoarding, she may have been self-neglecting, so there's garbage that's accrued and and they've smelled it, and the landlord's been trying to deal with her, or she no longer can pay her bills, so she hasn't been paying rent. Same thing with the home ownership. She might be facing, she hasn't paid the real estate tax bill, so she's facing a sheriff's sale, or there may be a foreclosure because she hasn't been paying the mortgage. Perhaps somebody convinced her, to take out a reverse mortgage. So these are the kinds of, so what they do is they come into the legal center, like Sophie will contact us, or with a social worker or another advocate for a different issue. I've been sued because they want to put me out of the building. That's like the number one thing that we have happen. And in speaking with Sophie, okay, then we began to, talk to her, and again, like I told you, then we have the ability to talk to her and, have a better idea of what her capacity is at that point. Can she make decisions for herself? If she can make decisions for herself, then to provide her with all of the options in terms of what she can do, maybe what her legal options are, the other services that might be there, supportive services that can get put in place to help her. But ultimately, as long as Sophie has capacity, it's up to Sophie what she wants to do about her situation. And even if we're engaged as her lawyer, there's this other part of lawyering, which is this acting as somebody's counsel. So providing them with education about what their options are, but ultimately the client is the person who's going to make that decision. If Sophie no longer has capacity, I will say the one area that we are not involved in is we are not involved in moving for guardianship against people. So we do not get involved with that at this point. And it does, and that's why I would say I encourage people, for yourselves to, take care of your affairs. Put your documents in order, have somebody in place, legally who can help you with your bills, because there are legal protections. If you just bring somebody in to help you, you're way less protected than if you name that person. But having those things in place well ahead of time is very, very helpful. Because ultimately, if Sophie has to be taken, she has to go to Orphan's Court to have somebody appointed to help her, she has no say who that person is. And it can just be a stranger. It could be a lawyer who has no idea about who she is, what her values were, what her likes and dislikes are. And that can be a not good situation for Sophie.
And one of the things I wanted to say is that one of the programs that we don't have in great availability to older adults is the money management program, which for people like this, sometimes what we find is we get the call because somebody was in the hospital. They've been in the hospital for, maybe they went into the hospital, then they went to rehab, they've been out of their home for 6 weeks. Guess what's happening? The bills are piling up at home. No one's there to pay them. And so that now they're in this dire situation. So we really desperately need these kinds of programs, as unfortunately we don't have them. I know, I'll give you another story quickly. We had gotten a call a number of years ago And this couple was calling us. It was an older couple living in their home. They both had medical issues, and they had home care. They were getting home care through the Area Agency on Aging. And they called us. They were referred to us because they asked for a money management program. And so when our staff person got involved with them, it turned out, and the reason they were referred was because they were running out of money by about the 10th of the month. They get their money on the 1st of the month, and then by the 10th of the month, their money was gone, and they were trying to get money from food from food banks and so on. And it turned out that what was happening to this couple was that they weren't able to get out of their house, so they give the next door neighbor $5 and say, could you get us a loaf of bread? And he got the loaf of bread for them, but nothing else came back, no change. And so little by little, and it wasn't only that, they still were getting their Social Security check in paper, and they gave it to the home health aide. And the home health aide took that check to the bank to cash it and brought it back, but not all the money. She kept part of that money. So, and they were afraid to complain about this because this is how they were able to stay in their home. And what they were afraid of was that if they told someone that they couldn't complain to the agency, they couldn't complain to the PCA because they were afraid, well, oh, they're just going to pull our services and put us in a nursing home, whether it's rational or not. And so they were just subject to this abuse constantly. So we got involved and we were able to unravel all of that. The aide got fired, prosecuted. We said, we found a neighbor, actually. We found a neighbor who could be trusted, who could help get that loaf of bread or a quart of milk for them if they needed it. So in some cases like this, it's important to look a little deeper at why this problem is happening. And in this case, it might be clearly that she's declining cognitively and she really can't do this, she has no one. But it also could be that she's declined and just can't do it for one reason or another, and with some help. Because while I say there's no money management programs, there may be some way to put something together for her. Maybe there is a family member or someone who can help her with these issues. So that's what we try to do, is kind of go a little deeper into what the problem is and try to help provide resources.
Quick comment, because I know we have to get to Q&A. The one time I would probably get involved in something like this is a couple of times, but a couple of cases that come to mind is when you have a family member or Sophie would have had to have been our patient before, and then we haven't seen her in a while, and the family member calls and says, we're really worried about her, can you come out to the house and see her? And at that point, our team would go out there. Our team usually consists of a physician, a pharmacist, and a social worker who go out to the house. We just do in-home eval to see what's going on in the house, how can we help. And I can't tell you countless times we've walked into our homes, they're covered in filth, there's pests in the house, bugs. We've seen some amazing stuff on these home visits. And so certainly if there's somebody who you know of who could use help with this is something that we can do for them. But certainly our resources are limited because we can only do so many visits in a day, and it's hard to open it up to the full public. But certainly if something like that happened, our first call would be to PCA, and then from there. Carry now, maybe.
We're going to call it a lot. Wow. Fantastic discussion so far. Do we all need a little break first before we go to Q&A, or do you want to go right into start the Q&A? I think you're not getting up to the Q&A. Okay. You can either raise your hand and stand up and make a question to one of the panelists. You can write something on the chairs. Okay. Let's start over here.
Joe had mentioned that in the 1950s, you were starting the process. Was there a precipitating event, historically, that caused that issue? Like determined the
No, I think it was just starting to be noticed that, we had child abuse, we had domestic abuse, and now we have elder abuse, and it's starting to come into the view of at least some representatives that we need to start doing something about it. Communities were saying, we have this, and can we get some demonstration projects?
Let's go around. Okay, yeah, Richard.
The power of attorney is taking money that should go to a nursing home for someone that has dementia. It's taking it to pay their own bills, and so the nursing home wants to threaten that person with family members will call some need under that person, and somehow they find some money and prevent the eviction from occurring. The second power of attorney is the wife. I guess one way to put heat under them would be, I would think, to call up Social Security, veterans, or Medicare, and maybe that would continue some heat and get the power of attorney to do the right thing. But if you do that, would those three agencies cut the money off?
That's a very common call that we get in our
Can I
budget.
ask this
Oh,
question?
certainly.
What if nobody wants to be the guardianship? Because that's, in this situation, that's a lot of work to get involved, fix all these problems. There's money owed to the nursing home. What if nobody wants to be the guardianship?
Right.
What happens then?
Yeah, let me just start with the beginning of this. And this happens unfortunately more often than it should, is that, someone lives at home with their daughter, let's say, and the daughter is, the Social Security check is going to support that household. And so they're depending on that. That's how they pay their rent, that's how they manage month to month. But, and a lot of times, one of the reasons, we all want to age in place, stay in our homes. But the reality is not everyone's able to do that. Sometimes people don't want to go to a nursing home just for that reason, because the money is needed in that household. And so you'll see that person decline, and oftentimes what precipitates that the nursing home placement is a hospitalization or something like that, it ends up being almost, a decision that the family can't make. And so what happens is they do continue to use that Social Security number. Now, someone who doesn't have the income to pay for or the resources to pay for the nursing home is most likely eligible for Medicaid. And so that application is done within weeks of when they're admitted to the nursing home. There's only a few things that you're able to keep money for. One is $45, I believe it is, for the personal needs allowance, which is the money that the nursing home resident has to be able to spend on buying whatever they need to buy. And then the other thing is for medical expenses. So if you have a supplemental policy to Medicare, for instance, you can pay for that. So you can keep that money. The family can keep that, continue to pay that premium. Other than that, all of that money needs to be turned back over to the nursing home. So that person who is the agent under the power of attorney should be writing a check to that nursing home every month to pay that money back. If they're not doing that, first of all, by the way, it is a federal crime to steal Social Security money. Unfortunately, I don't think they turn it in as often as they should. And I mean, from my perspective, I prefer that they do that, that they go through the legal means rather than go to the guardianship route. But it does happen often that it turns out that because they want their payment, and so it ends up going to Joe's office or some other place. Actually, most nursing homes have their own counsel, and their counsel will do the petition for guardianship. And what happens in those cases is oftentimes there's someone else named guardian. It's not somebody who wants to be guardian necessarily. It's an attorney. It's a professional guardian, not someone in the family. And in this case, it would very unlikely be somebody in the family, unless there was somebody totally upstanding who came and did that petition because they wanted the person who was the agent under the power of attorney was abusive, and they were able to prove that they could be more responsible, they could possibly be guardian. But oftentimes, I will tell you, and Joe probably knows this better than I do, judges are concerned about those situations in terms of families fighting or not agreeing on things, and will often name that other person a guardian for that reason, so that there's no fighting. So anyway, that's generally what will happen in that situation.
So let me just address a few things about, because I didn't really talk about powers of attorney. So first of all, power of attorney, healthcare or financial, are only triggered when the person themselves can no longer make decisions or speak for themselves, okay? And so I want to make that very clear. Somebody goes around using that power of attorney or using the funds, when they're supposed to be paying the nurse, but using the funds when the the senior themselves has mental capacity, that is a violation of their duty. I still think powers of attorney are important because that agent has what's called a fiduciary duty. They have a legal obligation to make decisions, to spend the money for the senior themselves, to follow the direction of the senior if the senior had left direction, okay? Here, if the senior's in a long-term care facility, okay, then by law, let's say that, you know, they're not eligible for Medicaid because there's enough funds still to be paying. They're obligated to be paying for that person to live in that home. So the good thing about that is that the orphans court is the court that oversees that, and they could be dragged into court, okay? They can be forced to provide an accounting of what they've done. If they've mismanaged the funds or stolen the funds, they can be seized by the court. And then the court has the authority to take away those powers and grant them to somebody else, okay? What we recommend in our office and when we write powers of attorney is oftentimes that you don't name two agents, first of all, because that creates, where you have situations, and the doctor can tell you that, that's a nightmare. You know, you have two people, they never agree, ever, in the family. It doesn't matter if they've always gotten along. So we do recommend that you have one agent, but you can also name a subsequent agent. So the person, you know, so maybe 10 years ago you agreed to be the agent, you know, but now it's a lot of work, okay? And maybe you're feeling like you can't handle that. You can say, I am forfeiting my obligations as the agent, but if there's a subsequent person, then the powers automatically then can come into place, and that person no longer has to go to court and have somebody else appointed. So this is where good planning is important in terms of what goes on. But the family situation of what happens in those cases, yeah, it's messy. It's messy, and it's not as quick as we would like, okay? There are emergency means of getting before the court, but it's not like within 24 hours usually. And there's a lot of fighting back and forth oftentimes between nursing homes and families. Sometimes that's because the families can't agree. Sometimes that's because you have an agent who's not doing their job, okay? Sometimes there's some confusion because, as Diane said, that family member may be still living in the residence. And the nursing home residents can still have a house. There could still be a house in place. And so there could be family members living in that house. So this is what makes it all complicated. It's not a situation of black and white. You know, with family law matters, everything is kind of in the gray. And so I hope that gave it a little bit.
Yeah, sorry. More questions. Quick comment for POA. It's definitely important to have one person, okay to have a secondary. Tell the person who your primary POA that you had them as their POA. Because a lot of times people don't know that they're the POA, so they have no idea what you would want, what's what, and then at some point if that person is POA and they say, I don't want to do it, then it's back at square one and you don't have anybody. So really important to pick one person and tell them.
Sure. One question. Yeah, back here.
I want to know, you don't have to be elderly to get help, right?
Get help.
What kind of help?
Say like, you live in a house you're renting from,
Do you want me to?
from real estate. But you never see the person that owns the house. You're only talking through the real estate. And you have like these people standing around your house. You need your rug taken up because you have an allergy to the rug. You have mice running around and no one comes, this is for John.
Okay.
No one, you call them and keep
very quickly.
Quite good.
Very quickly, if you did call us, we would get you to resources that help people who are under 60, and we give you those resources. You know, there are other organizations. We happen to serve the elderly. You know, I did want to mention, I think Joe did allude to this, that there is protective services also, which might not cover you, but it does cover people who are vulnerable, who are under 60.
Yeah, I certainly think that if you called the physicians, we would probably hook you up with outside help. I think it sounds like you've been trying to advocate for yourself a lot, but I think that you're going to probably have to reach out for extra help, and certainly folks like these guys would be where I would refer you to.
Yeah, there are some tenant groups that can help you, I think.
Well, see, I'll be 60 in December.
Yeah. We're not, you don't have to wait, you don't have to wait until you're 60. So I want to be clear that even if somebody calls us who's under the age of 60, we don't just like hang up the phone on you. So we're gonna make sure to get you. So we are not the only legal aid organization in Philadelphia, and there are other agencies that provide legal services to tenants who are under the age of 60. And so you wouldn't have to wait until you're 60 to get that. And certainly as a tenant, you have some legal rights and you have actual steps you can take, including sometimes escrowing your rent, that can prompt the landlords to respond and to make your conditions, because you have a right as a tenant to live in certain types of conditions that are, you know, safe and healthy. And if you don't have those, then you can reach out and you can get some legal advice and legal assistance to try to prompt the landlords to do what you need them to do.
Yes, sir. Okay, good. Some of the philosophical questions I think that applies to that. In the opinion of you as the panelists, why does it appear that the grade of America, even within our city of our state hospital, why is it upended by a millennial obsessiveness that appears to dovetail into every aspect of someone that's even 55 and older? So parenthetically, why is ageism something of a closeted reality that no one wants to talk about? But in every aspect of living, it's affecting those who are of age. So why does that exist in your opinion?
Sure. PCA. Race and race.
Well, yeah, it's a question that we've been asking for a long time in the field as we try to figure out why our message doesn't resonate. And again, not causing a generational war here between millennials and you know, older people. The millennials are doing a lot of great things. The millennials I'm hiring are just fantastic, and they have the work ethic, and they're doing great stuff. But it's something we often, ageism is alive and well everywhere. And we all don't get the benefit that we would have if it wasn't alive and well everywhere. And it's really perplexing to us because we've been asking this question for me for 30 years, for Diane, 20 years. What is it? Why doesn't our message resonate, and what do we do about this ageism just being one of the many issues that leads to that question, why it doesn't resonate?
Okay, say one thing. Sure. So the one thing that we all have in common as human beings is we're all aging. Right now is the youngest you're going to be. So why doesn't it resonate? Well, some of it has to do with a little bit, I think, a change in societal structure and not having contact, whether that's in a family situation, community structure. We tend to be isolated a little more. I also think that in terms of policy-wise, and Diane can talk about this, we knew that our population was going to gray at a fast, with a larger, older population. We've known that for a long time. And there have been a lot of advocates yelling about the fact that you need to be aware of this. We need to make sure that we're prepared for this, that people have support systems, that our communities are set up for this. And it fell on deaf ears. It fell on deaf ears. However, as a group, it's a large group. It's a large group with a powerful voice. And you need to engage in it. There are lots of organizations that are, but you have to demand that you will be heard. Because you're a lot of people. And actually, money-wise, you control a huge amount of wealth in this country. A huge amount of wealth in this country. So it is that sense of empowering is also the fact that we want people to speak up. We want people to say, and when I go out, I always say, I want people over the age of 60 to say, I no longer am going to tolerate being abused, being exploited, being treated this way. And if there are laws that are not protecting me, you, as the representatives, are going to listen to us because you have to. And the one thing that seniors have that maybe some of the other ages don't have is you vote. You vote, and the representatives know that.
But I will say, I think that there is another issue here, and I'm not sure that, I think many of us fear aging. We look in the mirror, not sure we know who we're looking at anymore. I'm aging myself, and it's the way it is. But it's not something that many young people think about. It's not, I can't wait till I'm 80. I don't think so. At this point though, I kind of can't wait till I'm 65 because then I know I'm going to have Medicare. I've said I finally reached the age where I'm looking forward to something, to aging. But it is true. We're just not, we don't embrace aging in the way. And so ageism is everywhere, but it's also within us, even those of us who are aging. And I can tell you, I've spoken to people many times, older people, many times, and I've said, I have a friend whose husband died, and I tried to get her to move into senior housing, and she said, I don't want to be with all those old people. And I can tell you, I hear that again and again. Talk to an 85-year-old woman who says, no, I'm not going to a senior center. I don't want to be around old people. But there are some things that, that we can do about that too. And, there's some models in some other states, and I think even in Pennsylvania we might have one, a model where of co-housing where people take care of one another. The younger folks will take care of the older people, or even vice versa. You can take care of their children or whatever. And so having multi-generational communities helps us to embrace aging in a better way, to actually see that older people are contributing. Young people need to be able to see that. But I also know that as an aging person, sometimes we go, my colleagues at work will go out to work after, go out for a drink after work, and I go in Center City here, it's become a totally different scene to me. I go out and I'm looking around like, ooh, nobody like me here. And so it is, but I go there anyway because they've got to deal with me. But it is, but anyway, it is really, it's something we all have to do, but it also is starting to get the younger folks involved. And I think in some ways they are, and some of the people that are working for Joe now, there was a time when we couldn't find social workers who were going through school to choose working with aging. I always would go in and talk to these groups of students, and I'd say, well, guess what? That's where you're going to be working because the jobs are there. But now they're actually going into it. They're starting school and they're saying, I want to work with older people. And that's a big shift, I think. And so, and I think some of that, I'll just attribute a little piece of that to the compulsory volunteerism that's happening in schools. Because children are at very young ages being exposed in a different way. And that's what we need to foster more of that. Because that's the only way we're going to do away with ageism, is to get that younger generation involved. I remember as a young child, and I was a brownie, and we would go out at Christmas time and sing carols at the nursing home. And I was terrified when I went there, because the nursing homes were pretty bad in the 60s, It really didn't look very nice, it didn't smell good. And so I was terrified. So, fortunately I had my grandmother, who was like the person I loved the most in the world, who made me feel good about older people. But it is very challenging, and we've got to foster those kinds of intergenerational relationships.
just have a couple quick comments, and then we're going to probably have a couple more questions. There is a really good documentary, and I'm forgetting the name of it. It's about this nursing home in Washington State where they have a preschool that's built in there, and so they're exposing kids at young ages to be with the elderly, and the elderly working with the kids. So it's keeping everybody young. It's helping to foster a community where children aren't scared of seeing older people or things like that. I will say geriatrics as a medical specialty is one of the least filled specialties every year in the graduating classes. So unfortunately, we're not seeing it as huge of a tick, but I do think as the baby boomers are aging and we're going to have an increased demand, you're going to start seeing a lot more geriatricians coming around. And I think our population is going to have to shift, I think, to how we take care of and perceive older people, because there's going to be so many of you guys. So,
Yeah, me too, you know.
I just want to add one other thing in terms of the legal thing. It's not only your representatives, but changes like in Washington are going on because people are going on their zoning boards. These are things you don't think about. Is where is housing that's going to be, helpful for seniors? Where is that going to be placed? And what's going to be next door? Is there a school next door, to that? Where's the community center going to be? Where are the preschools, the daycares? Why aren't these all so that people have access and they can get to it and they don't have to drive? And so we have to think outside the box in terms of how people get involved and the decisions, because it is stuff like planning, zoning, and we're here. It's no longer like we're saying, oh, that's 20 years from now. We're in it now, and as a community, we have to be involved. Just like when, the senior housing for the LGBT community was going on, that took a lot of effort from a lot of people, and it had a lot of zoning and where, getting tax credits and all of that. Well, look what you have now around the corner.
Great. Two more quick questions, okay?
Intergenerational interaction. William Way has a connecting generations program. Maybe some people don't know that. I've been in the program a long time, and this helps me share my thoughts with somebody who's in his late 40s, and I'm 78. And we argue. I complain about this generation, cell phones, compulsive use of cell phones. I say, why don't you give me a telephone call? I can't deal with just emails. I'd like to hear the sound of it. We go back and forth on what my generation doesn't like about the baby boomers, the millennial generation X. We kind of have fun with it. We don't have the arguments, but I try to let him see things from my point of view.
Good. You're an advocate for that.
Yeah.
Good.
Well, I'd like to see him more often. I get one very, very busy. One of these overachievers. He has his own business and teaches at Villanova, getting his PhD at the same time. Very little time for me, but the time is quality. So it's better than nothing.
Okay, let's have one more question, and then we're going to...
Okay, so there are two. So one is there a point where self-neglect is a qualification in itself for incapacitation? And then the other, so I work with family caregivers of older adults, so even though I'm advocating for them, there are a lot of times where I end up calling older adult protective services. And often that's because, there are a lot of resources, there are a lot of places where people fall through the cracks, they're over income, they're scared of, state recovery and all those other things. And so I end up having, or that there's a 3 to 9 month wait list to get assessed for PCA. So you end up having to call older adult protective services just to get somebody in there faster. And that seems, I always feel really bad about that. It's sort of like when, uninsured people use the emergency room, it just seems like a waste of resources and you have to get to that point. And so whether there's something in between. And then on the other side is that when, it's kind of what Dana was saying, that sometimes there really isn't this answer, there isn't a place for people to go. And so people feel like they go through this whole process, they call older government services, there's all this mayhem created, and then they're in the exact same situation that they were before.
So
talking about
A whole lot more,
ways
yeah,
in
sorry.
which people get caught up in red tape or not getting to the right resource at the right time it's needed? Is that what you?
Well, so say someone needs to be out of their house for self-neglect or, you know, for abuse, and there just isn't a place for them to go. They're, you know, then.
These guys should have answers for that.
So, yeah, there's a lot of information
Yes.
in your comment. That's okay. We've got time. And yeah, we're never thrilled when somebody uses older adult protective services to get people services faster because there's waiting lists or the process because it takes us. It stays on our caseload that whole time. And with the new changes, especially in the enrollment process in PA, I have people on forever, which just weighs down the caseloads of my investigators who have a lot to do. And as far as, you know, but it happens because people that use our system know the words to use to get it to come out there. And then it's a matter of, we always look at not only do they need help, but, you know, are they 60, are they without a responsible caregiver, are they unable to help themselves, and are they even at risk? If any of them are not, we're out. So as far as can self-neglect at a point incapacitate somebody, it can incapacitate you, but to be able to do something against their will is a different discussion. So you have these horrendous boarding situations. You have these places where you walk in and the roaches are falling from the ceiling, and we can go to help right away, but we can't force help on people that say, get out of my house. And we have no way, after we make our announcements, say, you know, this is really bad and it's a horrible situation, but they still maintain the ability to make an informed decision about it, and we'll be out of there. That's how it goes. Go ahead.
Is that an informed decision? You said something.
Yeah, I hear you.
That thought process actually compromised and goes to the decision.
Yeah, the best we can all do about that is, if we have a doubt, is to get an expert out there to tell us, is that an informed decision? And if they say to us, yes, and they can say to us no in one area and yes in two other areas, and we can get relief, but again, you're going through a whole process, you're going through the court, you're in front of judges who have certain prejudices on their own, and we can't bring anything that doesn't meet the standards of the judges because, you know, we don't want to do that because we're in front of them all the time.
I wanted to say that this is the kind of call that we get often, and I would encourage, you know, if you have these kinds of situations, to call our office, because when you say they're on a waiting list, and self-neglecting, it doesn't, to me, doesn't say that that person can't get help. And so if they're willing to get services, so they're on a waiting list, they've done, or maybe they're not on a waiting list. Maybe they're just waiting to get assessed. And so what we've found is that, you know, when our staff get these calls, a couple things we'll do. One is that we might intervene because something fell through the cracks, because that assessment shouldn't take that long. We can get involved in advocating to move that more quickly. We also can help if it's a waiting list situation, like for instance, the long-term care options program that right now has a waiting list. The waiting list situation, then we can help hopefully find some different types of services that can kind of hold things together for a little while. Maybe if it's a home-delivered meal issue, maybe we can help get some meals in there. There might also be a different option available to them. Like, for instance, there's a program called the PACE program, Program for All-Inclusive Care for the Elderly. In Pennsylvania, we call it LIFE, which is Living Independently for Elders, because we have a PACE program that does prescriptions. And so that program is a program where, you know, it can take a little while to get in, but not a long time. But if the person's appropriate for that program, they can get all-inclusive services, which means they're getting all their health care taken care of. If they do need a chore service to clean out the house the first time, that's happening. They can get home care in their home. They go to a center. There's many things that they can get that way. So we would try to troubleshoot if a family called us, and oftentimes it is a family, sometimes it's a neighbor, but it's easier if it's a family, calls us and says, you know, my mother, I don't want my mother to go to a nursing home, but she's on this waiting list, and I don't know what we're going to do. We can't do, because, you know, there's 3 different children, and they're all staying with her for different days of the week or something. So we would try to troubleshoot and find it. That's what we do as advocates. We try to find something.
Well, I think we obviously had a fantastic time. Tremendous amount of information. And by the way, there's some more information in the back. Before you leave, check out the table back there. Everyone brought the information about their services. Take some home with you. So,
Yeah, so a couple other just closing announcements. In your folders, there is an evaluation form that if you could take a moment to fill that out before you leave, would be a big help to us at the Elder Initiative, just to hear about what you like from the program, things that could do better for future programs, some of your ideas for the other types of programs that we can do as part of these conversations and other community forums. Want to also give thanks to Joe Quinn, who was our volunteer who spearheaded the planning. I also want to thank Frank Dietrich, who also volunteered on this program. And he said that he was going to help get us some materials and resources for the program. And I was literally getting boxes and boxes of mail from different state agencies for a couple-week period. So please do check out all the materials in the back. As Joe mentioned, many of our presenters brought some of those materials as well. And Joe mentioned this in the beginning, but there is this event going on June 15th for World Elder Abuse Awareness Day, where some of these presenters will be again. Flyers for that event are in the back. And again, just want to give my thanks on behalf of the Elder Initiative to Joe, Dana, and Diane, and John for coming on Saturday and donating their time and expertise with us.